By April 2020, the SARS-CoV-2 pathogen had achieved a global scale. Despite nations facing a similar viral threat, early case fatality rates showed sharp discrepancies from one border to the next. Medical professionals initially hypothesized that these deaths were dictated by transmission volume, the limits of hospital infrastructure, or the prevalence of specific comorbidities. To test these assumptions at a macro scale, researchers published this ecological study in Progress in Microbes and Molecular Biology. This research distinguishes between individual clinical outcomes and the mortality patterns of an entire population. Without mathematically decoupling these risk factors at a national level, public health resource allocation remains a matter of guesswork. In an ecological study, the unit of observation is a country's population, rather than the individual patient. The researchers isolated the top 50 affected nations to ensure a statistically significant sample size. They tested 4 specific variables. The first was healthcare capacity, measured by the number of hospital beds per 1,000 people. Second was baseline population health, represented by national smoking prevalence. Third was biological sex, measured by the proportion of males in the population. And the fourth was age, specifically the proportion of citizens aged 65 and above. The objective was to identify which of these 4 factors possesses the statistical power to shift national mortality rates during a pandemic. The team extracted raw epidemiological data, the confirmed cases and deaths, reported up to April 16, 2020. They paired this data with demographic indicators from the World Bank database to match the timeline. This chart plots a nation's confirmed case percentage against its case fatality rate. Luxembourg is a significant data point. It had the highest percentage of confirmed cases at 0.55%, but a low case fatality rate of 2.05%. Contrast this with the United States. Its raw case volume was less than half of Luxembourg's at 0.20%, yet its fatality rate was significantly higher at 4.85%. Raw transmission volume is statistically decoupled from the ultimate fatality rate. This decoupling forced researchers to look closer at the structural vulnerabilities of the populations. Linear regression analysis was applied to isolate the drivers of mortality. For a variable to be statistically significant, it must achieve a p-value of less than 0.05. The gender variable returned a p-value of 0.26. A nation's male population proportion did not significantly drive its case fatality rate. Smoking prevalence showed a p-value of 0.60. Baseline smoking rates failed to act as a population-level predictor of mortality. Hospital bed capacity yielded a p-value of 0.50. Baseline hospital infrastructure did not dictate a nation's early fatality rate. These hypotheses failed the macroepidemiological test, leaving only one viable driver in the data. That final variable is the proportion of the population aged 65 and older. This demographic factor showed high statistical significance, with a p-value of 0.035 and a beta coefficient of 4.70. This means for every 1 unit increase in the proportion of elderly citizens, the case fatality rate increased by 4.7 units. This graph maps case fatality rate against the proportion of the population 65 and above. Below 0.10, the mortality rate remains flat, but the data reveals a critical demographic threshold. Once a nation crosses 18%, the mortality rate begins a sharp geometric climb. Mortality risk is structurally governed by baseline age demographics, activating exponentially once the 65-plus cohort exceeds 18%. Why does age trigger such a vertical spike in the fatality data? This is the macro-scale result of a biological process called immunosumescence, the age-dependent functional decline of T-cell and B-cell performance. As the body ages, the immune system overproduces type 2 cytokines. This extends pro-inflammatory responses and allows the virus to replicate more effectively. This weakened state is further strained by the accumulation of comorbidities, like hypertension and diabetes in populations over 65. The 18% inflection point on the global map is the mathematical shadow of cellular immunosenescence occurring in millions of hosts simultaneously. These results hold immediate implications for public health policy. Transmission reduction models remain incomplete if they do not heavily weight local age demographics. Preventing healthcare collapse requires aggressive, targeted shielding of the 65-plus demographic, rather than solely reacting to general infrastructure shortages.